Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nyros. And today on the Wealthy Podcast, we are talking to Dr. Ryan Foster. Dr. Foster is an ICU physician here at Kelowna General Hospital. And today we get right down to it, talking matters of life and death and what it's like when you have a loved one facing time in the ICU. On today's episode of the Wealthy Podcast, I am sitting down to literally talk about matters of life and death with a KGH physician that is near and dear to us, Dr. Ryan Foster. Dr. Foster wears many hats. He is the medical director of the Interior Health Critical Care Network, a member of the newly established KGH Trauma Service, and he also serves as a director on the KGH Foundation Board. Very important job. Volunteer job, I will say as well. But perhaps his most cherished role is the one that is the most personal. Dr. Foster is a critical care physician in the intensive care unit at KGH. Like many of his colleagues working in critical care, he's been through a lot these past several years. But even before the pandemic, the nature of the work is such that the fragility of life and inevitability of death are ever present. Critical care doctors working in an ICU face complex ethical questions that often arise in the emotionally charged environment of critical care. Wow, this intro, I just nailed it. Hey, it's so good. Amazing. I'm going to keep going.
Makes it sound important.
But the ethical dilemmas that you face are very, I think, underrepresented when we talk about critical care. And I'm really excited to get into some of those questions because unless you've actually experienced a loved one going through navigating the ICU healthcare experience, you wouldn't necessarily think about these things. So Dr. Foster can offer a perspective on healthcare that is valuable, especially, as I said, for those of us that may end up supporting a loved one in the ICU. He is funny and humble and kind, and I'm honored to be able to speak with you today. Dr. Foster, may I call you Ryan?
Please call me Ryan. Thanks.
I call you Ryan,
yes.
like in most informal settings.
Yeah, I appreciate it. Thanks for the intro.
Yeah. It's great to have you. So I'm going to start. We have an opening tradition on the podcast.
Right.
I make sure that we ask every single person that sits in the hot seat this question because it's important. I think that everybody that sits there comes to the conversation with sort of a deeply held passion and commitment for health. And I would just like to know where yours came from. Like, where did it start? What maybe was the first sort of like experience, or what inspired you to kind of take this path as your professional, adventure that you're on?
Thanks for all the kind words, the intro. So I come from a family of physicians. I had a grandfather who's a general surgeon back in like class of 38. So that's almost 100 years ago, which seems crazy. He was a general surgeon in Ontario for years and years and years. And then his daughter, my mom, Robin's a pediatrician. And then around age 50, she switched gears to do public health. So she's been a public health physician in Ontario and retired, or trying to retire, sort of.
So she's still...
she still does some work through Canadian Pediatric Society.
Yeah.
Knows some of our local peds team. And so she has some role there. She's retired formally from any sort of day-to-day clinical work, but tried to sort of back out slowly at age 50 and thinking, public health is a way to maybe do a little less nights. And of course, that was quickly followed by like Walkerton and then SARS-1 and SARS-2.
Right.
And like COVID, and it couldn't be busier when you're talking about public health. So her swan song sort of late career change just got busier and busier. But so, and then my father's a jack of all trades family doc who had done a little bit of everything growing up. And, he was from the old school model of, surgery was on Wednesdays and doing babies on, nights, and lots of work. But one of those, the style where you the blurred lines between where does sort of life, personal life end and and professional life begin in a small town, Niagara Falls, Ontario, 70,000 people at the time. I remember we would go to church and he would spend like, out on the steps afterwards would be 20 minutes of like saying hi to all his old dollies. And he'd say, oh, these are all the old dollies from work. And, know their family. I delivered the baby, the granddaughter. Like, so I was kind of immersed in the, the family side of what a medical career looked like. Of course, I wanted to be a vet. I was like, I don't want to do humans. I want to do animals. And that comes from, I remember my dad came to Beavers when I was 6 and he put a cast. He was showing all the kids how to do a cast. And he put it on the leg of one of my teddy bears, and I thought it was the coolest thing I ever had, this like a cast on a teddy bear that all the kids would, can I have the cast, to take home?
Yes.
So there was a lot of sort of priming, I would say, in terms of that kind of career.
Like, did you ever?
There wasn't pressure necessarily, but
yeah.
It was, I would say, having played lots of sports and football and this and that, like lots of sports injuries, I kind of thought, okay, I could see being an orthopedic surgeon, that's kind of what I could eventually see doing, kind of thing. So like I didn't entertain a lot of other options. My, older brother went down sort of hotel and food and
like hospitality.
And my younger brother went off to do teaching and IT stuff. So there wasn't any pressure, but it just kind of evolved.
It's in your DNA, I guess. So you didn't ever consider like, oh, maybe I should be like a marketing executive, or
didn't come up. And you remember, like, this would be, I'm dating myself, but Last Millennium TV, so like ER was like that's where it was at, so Dr. Peter Benton and Mark Green, you can't go wrong. And
you're not dating yourself with me.
But because Mark Green, if you recall, was from Top Gun, which was the all-time favorite movie ever. You're like, that guy can't be doing it wrong, and he plays a doctor on TV. So, so
you sort of look like that guy.
the bald and the full head of hair. So anyway, and then just through you have some friends, whatever, and a buddy of mine was a couple years ahead, and he had gone off to Western, and then I showed up there, and he quickly went off to U of T for meds, and I was like, well, that looks pretty fun, and that's what I did. I went to Toronto,
and here you are. Amazing. I'm curious because you've mentioned sort of like you were thinking about being a vet, and there was I guess there's lots of options in terms of medical specialties. How did you land on critical care?
That's a good question. Like I had some really good mentors when I was in like first and second year med school, and they just through luck of the draw, they happened to be really strong internists. One guy, Danny Panisco out of Toronto Western, Maria Bacchus, like people that I really looked up to. They were internal medicine, specialists, seemed to know everything, and really like competent physicians. And, you spend hours with them learning physical exam and pathology and all this stuff. So I was primed a little bit with some of the people that I had exposure to early, that I went into internal medicine as a specialty. And in those 4 years, you get exposed to all the other medicine specialties. So if you think of like, there's all things surgical, and I knew pretty quickly I just didn't like the tie to a hospital and OR, a team, and the nights, and like I just was like, I don't see doing surgery. I can't stand there for 8 hours in a row and do it again the next day. So full respect to the guys who do it well, and guys and girls. But anyway, I knew that wasn't on the radar. So in internal medicine, then there's about 18 subspecialties: ID, cardiology, endocrine, resp. Like every system has a subgroup that they all start together in internal medicine, and then you splinter off in years 4 and 5. And so you get a lot of exposure. And one of those I rotated through was ICU, and I was in that in second year thinking like, I really like this. Like, not only is it intense, but it had some almost an emerge like career, which is that it has some pretty defined endpoints. I start at 8 a.m. I bust my ass really hard for 24 hours, but at 8 a.m. tomorrow, I go home, turn the phone off, sleep, go for a ride, whatever, and I come back the next day and do it again. And so you're in these sort of like intense blasts, but it doesn't bleed into, I got to review labs tonight when I get home because I ordered, and so needs an insurance letter that I promised would be due tomorrow. Like stuff that I was not loving about the way medicine was set up in lots of other specialties. And so again, I had some really good mentors in my ICU years as a second and third year internal medicine resident. and quickly was like, yeah, I could see this being a neat way. And most people do ICU plus something else. So I was like, well, I'll do internal medicine, and then I'll do ICU. And it was a 2-year fellowship. And so when I first came to IH, I was doing all internal medicine locums.
What's internal medicine?
Well, it's the grab bag term for all of those subspecialties. So
yeah, I'm trying to deconstruct in your body.
Yeah, you say what about a liver? Is there a liver specialist? Hepatology. Did that start with internal medicine? Yeah.
Okay.
So we were sort of talking about specialty problems in smaller parts of the country, like IH. But let's say if you go today to Cranbrook and you say, hey, I'm having a heart problem, there isn't a cardiologist in Cranbrook,
right.
But there's a really strong group of internal medicine specialists that do bit of heart, bit of lung, bit of stomach, bit of GI, bit of
so they're like the GPs of
adult medicine.
acute care
adult medicine. Yeah.
Huh.
Yeah.
Interesting.
And so that's the model in Penticton, Vernon, Trail, Cranbrook, all our regional sites. Those ICUs are built on the backs of really strong internists. And then when you get to bigger centers like Kelowna and Kamloops, then you can have just ICU docs because we have enough volume coming through the door to keep your skills up, be busy. And so, that hub and spoke model is we try to support those regional sites, but bring the sicker ones locally. And often they have to come because they need neurosurgery, thoracics, vascular stuff that those places don't have anyways. So.
Right. So for anybody who's listening that might not pick up what qualifies an ICU physician, like a specialty in that?
So nowadays, since 2006, it's a 2-year fellowship with an exam.
Okay.
So actually, those poor guys are writing their exam. I think it's next week.
Oh, those poor guys.
Wednesday, Thursday. There's probably 65 of them across the country that are sweating buckets right now.
Okay,
guys and girls. I mean, international but they're writing the Canadian board to qualify for their ICU designation.
Wow.
And but before that, it was, do the 2 years. It was a certificate sort of saying, yeah, you spent 2 years in the ICU and the university would give you the thumbs up. Now the Royal College, the national board, sets the exam, says you got to do these 2 days of writing, you got to pass at this, and then you get the designation of critical care physician.
Wow.
The interesting, just one last piece about the career is that 2-year thing, you can basically get into that with any other specialty. So I did internal medicine, but if you go into my group right now of the 8, some have done 5-year emerge and then 2 years of ICU. Some did anesthesia for 5 years and then 2 years of ICU. One of them did cardiac surgery for 5 years and then 2 ICU. So you can do any subspecialty and then add ICU to it.
Interesting.
And it gives a really, our mix here is really good. It isn't all just internists. It's not all surgeons. And so we get to banter back and forth. When you're struggling with a tough patient, you can, bounce it off your colleagues and be and they'll, sometimes through a surgical lens, they'll have a different take on it. Or
what does it mean then? Because I understand your patients sort of run the gamut, right? Okay, going back to the ER or the Grey's Anatomy or whatever, the patient is in critical care.
Yeah.
What does that mean?
In
what's
general,
the distinction between critical care and stable?
Yeah, I would say, so to take one step back, which is if you look at all those specialties, they tend to be vertical following an organ system. So if I say I'm a respirologist, I do outpatient asthma and I see COPD patients with smoking troubles, and in hospital they get exacerbations, get admitted, and I help in the ICU with bronch and super sick asthma patients. So they kind of follow healthy to super sick in a system.
Right.
Heart does the same, right?
Yeah.
Minor problems, chest pain, inpatient, super sick, cardiogenic shock. Whereas ICU, all I see is the sickest of that group. It's a specialty that catches only the sick ones. So I'm, 99% of the time I'm completely useless to my family, right? They're like, what do you think of this little? I'm like, I don't know. You're walking around.
Tickle in my throat.
Yeah, you're walking around. You have a blood pressure and an airway. I don't really know what else to do. I can help you if you're unconscious. Then I can help you. Otherwise, so it's a bit unique in that we spend a lot of time dealing with just the sickest of the sick in all those specialties, not in the well. And so we in almost all those kinds of patients, we then pull in the relevant specialist as well. So if I'm really struggling with a heart patient, low blood pressure, troubles with their heart not pumping, I'm absolutely leaning on the cardiac team, cardiologist, interventionalist, cardiac surgeon, to also weigh in on what are we going to do with this patient.
So I think I read that it was like the 1% of patients, the like sickest of the sick.
Yeah, like I would say if you like say Kelowna General, right, 275 to 300 visits a day to emerge all year long. That's 100,000 patients a year. KGH, and we track this data pretty granularly. We see about 2,200 patients as consults or admissions to ICU in a given. So that's 2%.
Wow.
And so you can see how, like, I mean, we sort of talked about, like, it's a little bit of a black box for most people because, like, you just don't see it. You don't come across it. You sort of see it on TV, and they always seem to do amazing. And they've done research into looking at, like, look at the outcomes of cardiac arrest on TV. They almost all survive, which is not true in most of the real world. You know, Grey's Anatomy, like, they'll have a 90% survival rate for when they're doing, like, you know, call it cold blue, and they're doing CPR and stuff. Like, it's a complete misrepresentation of reality, but that is what most people think of the ICU. They sort of think it's acute and busy and stuff.
Well, and also true. Heroic, right? Yeah. Like, save the patient.
Yeah, absolutely. So I would say, that it's hard for people to understand because they just don't get exposure to it that often. But like you said, you know, when you look at, you know, there's 24 patients in the ICU this morning here at KGH, and the layers of onion around each one of those is probably impacting, you know, 3 or 4 core family and 10 people, and then maybe 50 on their social media. Like, how's he doing? What's going on? Like, so there are these ripples of effect, but the actual number of ICU patients is quite small.
And so what is your job then? Like, because obviously, you know, like you said, you have 24 patients. One could be sort of like the sickest cardiac patient. One could be like the sickest cancer patient. What are your priorities?
Yeah, so we lean heavily. Like, I have an amazing team, right? It's the one thing that ICU...
We've heard this time and again about ICU.
Gets is we get an amazing amount of resource. We got, you know, let's say like today there'll be, you know, 17, 18 nurses at the bedside to cover those patients. There'll be 3 educators. There'll be social work, dietitian, speech language, physio, charge nurse. You know, there'll be 3 of us intensivist physicians over a 24-hour period. You know, porters, like, and all that stuff, like, comes together to really help, you know, the ones in front of us. Yeah, you know, first thing in the morning, 7:30, we're triaging, like, who's sick, needs to be seen right this minute, who can be seen in a couple hours because they have a plan, who unfortunately has bad organ failure but is stable in a way that we're waiting for brain to recover, we're waiting for lungs to improve. Like, so, you know, in my list of, say, 8 to 10 people that I'm trying to keep an eye on that morning, you are quickly deciding, you know, who's ready to go to the ward, maybe they're improved,
right,
who needs attention right away, who can sit tight for a few hours. So that's a constant battle, and that's part of what ICU is that, and you were saying what defines a critical care patient. In general, you need some kind of organ support.
Right. Okay.
You know, so if your lungs aren't working, you need a
ventilator.
Or to heart's not working, you need medicines to make it pump. You know, kidneys aren't working, you get dialysis acutely. You know, so there's a lot of sort of like trying to figure out.
An intervention to keep you alive.
Exactly.
Yeah.
And half the time those are crutches, right? It's a crutch to buy you time to do some other therapy, antibiotics, surgery, time.
Brain heal.
Yeah. Like
time.
Half the time it's just like we're trying to support you through and let nature do what it can do, which is try to heal on its own.
Yeah.
Hopefully.
Wow. I mean, simmering underneath all of this is the conversation that I want to have with you around some of the really difficult decisions that you're having to make, let's say on any given morning, just about, you know, keeping, when your job is to keep people alive or keep people comfortable, and then having to interface with the family members, because many times those individuals, I you know what, I'm totally like Grey's Anatomy in my head on this, because I've never been in an ICU other than to film you guys, you know, but like sometimes the patients are not conscious, and so you're interfacing with family members. So there's a whole layer of expertise, I guess, so like compassionate care. Did you know that was going to be part of the deal when you stepped into this? And we can get into some of the bigger questions,
yeah,
but like
you knew
in
it was
general.
some of it. But you can imagine like the front end, learning of med school and internal medicine and ICU. You spend a lot of time stressing about things that are important, the diagnostics, like what's the right test, what's the right treatment, who do I. But as I'm more senior in my career, and I absolutely you start to realize like, look, the right antibiotic you're going to probably come up with on your own 80% of the time, and if you don't, you've got 6 other people that'll know it like instantly.
Yeah.
So you don't have to stress like, is it Tazo, Maripana, Vanco? Like, doesn't matter. What matters is the family in the room, how they're feeling, how they perceive you treating their loved one. That's far more important. The family would never have feedback that said, I think they chose the wrong antibiotic. They will have feedback to say, I didn't feel we were heard, or no one told me what was going on, or I didn't know what to expect. Like you start to, and again, it's not faulting the system, but the concept of you don't know what you don't know. In those early years, like it's really hard. You're so stressed trying to, tick box all the right like diagnostics and what's the next test and what's the diagnosis, and that's what the exam is. The exam is much more focused on what are you going to do, what's the right answer, et cetera. But being able to navigate the complicated expectations, try not to crush hope when statistically things are really bad. And I always say to families like, statistically this is going to go very poorly. Your loved one is not a statistic. We're going to do the best we can in the setting of this, but just so we're all on the same page, we're coming to the table here with really
the deck
things
stacked against us.
Exactly.
Yeah.
And it's a really fine balance. And honestly, you sometimes get it right and it feels really satisfying. A good death can feel really satisfying when the family feels like we did everything that was appropriate. We changed to palliation because it made sense. It was a comfortable death, and you can leave feeling that you've done the best for the patient there that day. And there's times you miss the mark and feel like, I should have been more XYZ over, the messaging or repeat messaging or whatever, So, and I think although the training programs try to promote that, I mean, you sort of learn a little bit as the years go by. And
it's very nuanced, like you said.
Yeah.
It's not, I don't know. I mean, I don't even know what you could do to prepare students for that.
Yeah. Like, I think I would say 9 times out of 10, you get the patient, get it sorted, get them in the ICU. They got a plan, the nurse, everybody's happy with what's going on. And the final piece of I should update the family is the one that often falls because you feel like, I've done all the good stuff for and there's nothing worse than the family coming in the morning and saying, they're not on 3 East anymore. Where'd they go? Oh, they had a problem, went to ICU. Like, no one called. Like, it's like, like those kinds of, it sounds easy, but there's a ton of information overload coming at you. And your priority is the patient care, no question. But we're learning as the years, you learn as the years go by, and the expectation that the family is just as much a part of the ICU team as any other member, you know. And in fact, we're right in the middle of one of our big kind of pushes over honestly, COVID kind of wrecked it a little bit, but is
disrupted.
Trying to have families in the ICU as part of rounds. Yeah. I say RT, anything to add? What do you think, dietitian? What's going on nursing wise? Family, any, it's just one part of the team. And that's a whole pendulum shift from the paternalistic, this is what's happening and you're lucky I updated you at all.
The family's sitting in a room, a waiting area, and you come out and it's And I think, one of the things that you said to me also, oops, I guess I didn't turn my phone off. It's my birthday today, so my phone's very busy. Yes.
Birthday.
But one of the things that you said to me is that critical care is very poorly understood. It's misrepresented in these dramatic television shows, right? And so a lot of people don't really understand until you're in it. Yeah. And I do appreciate that there is a place for families as part of that critical care team.
Yeah, it's crucial.
I think it really is. So you've kind of referenced the nuances of your work, what you can do for a patient right? In terms of like a lot of what you're doing is either keeping them alive or allowing them to pass in a way that feels dignified and comfortable as possible for both the family and the patient. So like, can you kind of unpack, like, modern medicine can keep patients alive or on life support for a very long time. But sometimes maybe that's not the answer.
100%.
Can you unpack that, like the what you can do versus what you should do, and how those decisions are made in conjunction with families and care teams?
Yeah, no, I mean, it's a big part of what we do, because as you highlighted, the default tends to be do everything for everybody as long as you possibly can, and let's just that would be,
because it's that way in other specialties, right? Like it's like keep them alive, right? Yeah.
And I think if you say to most lay people, or let's say, hey, your mom's sick, do you want her to live? They say, yeah. Like, what are you talking? Yeah. Do everything you can do that. And I think what's changed and what we try to promote it would be, let's do everything that's reasonable, because what we're trying to get away from is, quite frankly, prolonging suffering. If you truly think you're in a situation that is not fixable, that we are, and I mean, like, just sort of generically, going to need life support forever in major ways. So you could say, well, what about an ALS patient who uses a breathing machine, life support at home, and can have 2, 4, 6, 8 years? Like, there's obviously nuances of all of it. But I would say when we get into situations where we feel like truly we're using the ICU resources, lung support, kidney support, heart support, and there's no way out of this, they're too sick, this is not survivable, and we're only prolonging suffering, we do need to go back to the families and say, this isn't working, and let's switch the care plan to focus on comfort and not just, and then that's the whole quality versus quantity, saying, let's not just prolong the quantity of life. And I often say to families, like, can we agree that this can't be your loved one's new normal? They wouldn't want this. No. XYZ super sick on, if we're doing the same thing at Thanksgiving and at Christmas, like, does that feel like a win? And most of the time families agree, like, yeah, the quantity as the marker of success is no longer reasonable. It doesn't mean, it opens up the whole really tough discussion around, like, what is quality of life? Who gets to decide that? Well, it should come from within. So I don't get to say what your loved one's quality of life is. And I often tell families, I say, like, look, I'm going to bring to the table my best guess as to what, best and worst case scenarios look like. And you got to bring to the table what they would say about that. Yeah. And if there'll be times where it's very divergent. You say, best case scenario, they're, trach and fed and they're cottonwoods and never have a cognizant thought. And some families go like, well, she might think that was okay. I'm like, really? But like, I don't get to define it. No. And other times people say, like, oh my gosh, if he can't be riding his motorbike, playing Sudoku and,
holding his grandkids.
He wouldn't want to be here. And you say, that's very helpful because I can tell you with certainty that won't be what the outcome. And so we try to line up the goals of what I think the outcome medically will be. And they try to provide where the patient would sit and you hopefully come to a resolution. Doesn't mean that, culturally or, as you know, like, there's no such thing as like a normal family. Right. Everybody's, and I get, my team and I, but, I selfishly get this front row seat often to a very, like, you're parachuted in the middle of, like, the worst thing that's happened to this family in a long time. And the dynamics are unbelievable. Every time I think I've never seen that before, I'm like, oh my gosh, like wait till next week. Well,
it's not something that you like, oh, it's Thanksgiving dinner. Let's talk about what we would do in a situation if one of us ended up in.
Yeah, had a huge stroke, wasn't going to ever wake up. What do you think of that? Like, it doesn't come up. Yeah. But I often say, like, well, tell me what kind of quality of life did they have before? What brought them joy? What was like, and what things would they say as a non-starter? Like, if I can't do, I don't want to flog on. So. Yeah.
Folks, have the conversations. I know it's uncomfortable, but
the GPs and hospital, like, there's a lot of awesome resources out there. I would say it's undervalued in terms of promoting the discussion, but I promise if you raise it with your primary care, they're happy to say, hey, this is a great opportunity to sort of have even a gestalt as to, where you'd want to be. And,
and I think that's the thing is like when you're healthy and you're living your life, it's a really good time to think about that, right? Because you're not like, there's not a lot of other distraction or noise in the way. Like when you get sick, then all of a sudden it's like, there's other things that start to creep into that thought, into that, what do I actually really want? Right? So having the conversation with your loved ones while you're healthy, like I said, it's uncomfortable and a bit dark, but at the same time, it's like, these are my wishes. Like if anything ever happened to me, if I was in a serious accident, I had a major medical crisis, a stroke or whatever, and if I can't do these things, that's not living for me. Right? And then you kind of take the pressure off your loved ones too. Yeah. Right? God forbid that any of us have to end up in that situation, but it does happen. You see it every single day.
All the time. You hear people say things like, we never really talked about it. But I'll often, and again, like I would say, most often what needs to happen is time for families to truly appreciate where we're at. We can open up the whole can of worms of trust in physicians and, misinformation, all this stuff. Like, it's really difficult. You say, here I am with my loved one. They're super sick. And I've got someone I've never met before who just parachuted in the room and said, this is going badly. I'm not sure we're going to survive. What do you want to do? Like, you say, I don't know. You've created, and I say to the residents, like, you're not going to be able to gain their trust. Do things that are trustworthy. When you say you're going to come back, come back. When you say, I'll track down this. Do you want me to call? I'll often say, do you have a physician in your circle that you want me to call? Because sometimes hearing from someone in their circle that they trust, all those tricks or ways to communicate help families. But I would say often it needs time. It needs time for them. If I say they're never waking up, 2 days, 4 days, 6 days, a lot of times families realize like, okay, yeah, this can't be the new quality of life. They would never want it.
You'd need a minute.
Yeah, exactly. Yeah. And so we're more than happy we try to promote it's constant tension between what do I think is prolonging suffering, but what we need the families to come along if we're truly in a futile situation, because it makes the death or whatever the planning is that much more, I don't know, say palatable. I mean, but maybe
acceptable.
Yeah,
I get that. Yeah. So you said a couple of things in there I'm curious about. So first, misinformation. I'm sure this must come up. I've got kind of on the list of some of the more nuanced or complicated conversations that you must have is, the brain death or, and again, you're so right. It is not represented very faccally, I guess, in or dramatic television shows.
Or infrequently.
So, but it's like, what happens when, that this particular patient from a medical perspective has a very poor prognosis for waking up and having the life that they had previous to whatever it is that caused that. But then you've got the TV show that the story, the miraculous wake up after 5 years or whatever. Like, what do you do with that?
Yeah. I mean, you try to give the family or the advocate, time and space to share. Yeah. Understand. I mean, I try to stay away from dissecting a whole other case.
Like somebody else's.
Or I'll say because most of the time I'm like, that's very different. And I'll and again, sometimes we blur the lines, and I my own team sometimes as well. I'll often emphasize guys, traumatic brain. When I smack my head from a car accident, and post-arrest brains, I overdosed and had no oxygen. Those are very different cats. Oh. On day one, they're both comatose. Day two, they're both comatose. Yeah. The trauma guys, it's a very different group. It often tends to be 20, 30, 40-year-olds, first of all, but the literature tells us like that kind of patient population, you can wait a long time before you have some certainty. Cardiac arrest is so common. We have a lot of literature around. Like,
so let's look at those two cases then.
When we shouldn't be prolonging suffering. And I often tell the families, like, I'm sorry, you told me like you had the 20-year-old cousin who woke up after a year after a car accident. Fair enough, that may have happened. Like, I don't, but this one in front of us is your 80-year-old grandmother who had a cardiac arrest and had 30 minutes of CPR. Those are different. And people, through no fault of their own, like you said, you don't see it. No one learns about it. No one talks about it. And you just assume that all comas are the same. All decreased level of consciousness is the same. It's not true. And so that's my job, is to keep emphasizing, like, I'm sorry, or, you're in this group. I think we should wait 6 months. I think we should give it a long time.
The traumatic brain injury group has a better opportunity.
Yeah, I mean, these are nuanced discussions, but at the end of the day, like whereas like, man, when I see a post-arrest, there's some very clear features we know about, non-shockable rhythms, unwitnessed, didn't get them back within 15 minutes, like where you can say, I can tell you based on the literature of thousands of patients, this one has never waken up. I'm so sorry,
right.
And not that we need a decision right now, but I need to tell you that's my biggest worry. And then, I guess to speak to that, when you really are bringing down a prognosis that you really want the family to appreciate, and you're not asking for decisions or anything, but just saying, look, this is where we're at. Let's talk more about it tomorrow. We'll talk. I then bring in as many other people bring in neurology, bring in my, maybe another intensivist tonight, on the night shift. Can you weigh in and, write also an opinion? Like, because I think the more times the family hears it from, same messaging from multiple sources, is also helpful. And like I said, because we get in these super uncomfortable positions, you're parachuted into the middle of the worst thing that's ever happened. They've never met you. And of course, how do you expect them to, I'd be skeptical. I'd be like, sorry, who are you? What's your name again? Like, how did you get invited to the table here? Like, so it's tough. It's really tough.
And you also mentioned like this delicate balance between hope and like the reality, I guess, maybe. Yeah. I don't know. I mean, I think you could probably hold both.
You can.
But I don't know if there's any other situation, maybe an emergency, where you're having to grapple with that so immediately, right? It's like, wow, we're here now. We're at a place where we're contemplating our loved one's life or death.
Yeah.
Like yesterday, we were just eating lunch.
Yeah.
So I think it takes a minute. I don't know. I can only just try to empathize with these families. It takes a minute to like process, because your immediate default would be, well, there's got to be something we can do. There has to be hope. Like, if there's not hope, then what? Right. So really interesting. And now I have a whole lot of more compassion for what happens in the ICU, because again, I think most of us just think it's like all right, well, we'll intubate now. And, this kind of like high charged, high emotion, high stakes environment. But it's kind of like we've been saying, it's that place where these big questions come up so immediately.
100%.
Yeah.
I was going to make one last comment about it, and of course it escaped. Oh yeah, I was going to say, and we know this from multiple other realms of life, but when people are in fight or flight, when they're revved up, because mom had an arrest and now we're in the trauma bay, and like I've learned painfully, personally and professionally, like people don't hear, they can't. It's just part of like
for real, so, they don't hear.
Yeah, they literally are like. You say, your mom had an arrest, I'm worried. And then it's like, you may as well be like the mom from Muppet Babies in the 80s. You're like, but,
they're gone.
And I say like, oh, I told the family. Like, and I document, family's aware, I told. That doesn't mean they heard it.
Yeah.
And you learn quickly, like, you need repeat messaging. You need different people to be heard. I often will say, is there anyone else that, who else is here with you? Oh, so-and-so's parking the car. Amazing. Let's wait 5 minutes for so-and-so to come. And I'll often say, let's write it down. What do you want? If you have any questions, write them down, because you're going to totally forget them. But like, and I'll come back in half an hour and we'll go through and we'll talk about it again. But you learn, like, in those first minutes, hours, even the first day, as much as I want to believe like, oh no, we had a good discussion, we talked about it, the literature, the research around like, traumatic events of any kind, we know that the processing is just not, it just doesn't happen. As much as we want to believe, no, I told them. The number of times somebody would say like, well, no one ever told me this was going to happen.
You just hear it time and again.
Yeah, and you try to, the immediate reaction is to feel like, angry or like we didn't do a good enough job or like, but to understand with some compassion, like this is the inability of like, communication requires not only a message, but a receiver. And if the receiver is turned off, like it doesn't matter,
Do you think they teach that stuff in medical school? Or is that
enough.
More mentorship? Yeah.
Yeah.
Because that's like actually
that's hard.
Well documented, I think.
Totally.
But it's one of those nuances that like really important for people that are experiencing this, like to have a person with you and also for the physician to be like, you're going to tell them and write it in their charts or their notes. Yes, family's been told, but they're in that, state.
Yeah. Like sometimes and again, this is a whole sideshow around communication, but like if you prime them, so let's say it's not an immediate emergency, but let's say so-and-so shows up with weakness and I'm like, this looks something bad and sinister. I think this is going to be ALS, or I think this is going to be a Guillain-Barré, or like I might, say, hey guys, like, your loved one's here. He's pretty sick. We got him on the breathing machine. I'm worried about a couple different options. And you can almost sort of plant the seed so that they can start to build a frame around like, oh my God, could this be something that's terrible? Let me get the neurologist's opinion and I'm going to get some tests and we'll chat tomorrow morning with when we have a bit more information. But when you give them a little bit of framework about what might be coming, it just makes the delivery of something terrible at least like potentially more.
Start to socialize it a bit.
Yeah. Like it's really hard when you bombshell something with no prep. You say, wait, what? Like you said, he was mowing the lawn this morning. We had lunch, and now you're telling me, may not survive the weekend. It's like, yeah. So when there's that opportunity, I try to say the bad stuff. You say, look, this might be a terrible cancer. I'm not sure yet. There's something very unusual with the CAT scan. We're going to get all the information we can. Might be infection, but cancer has to be on there. Look, he's 75. Like, you sort of say the words, so that at least you can almost feel like you're priming.
Soften it.
A little bit.
Yeah. All of these very nuanced aspects of delivering medical care that go unwritten.
Yeah.
It's wonderful that we have an opportunity to actually talk about it. I'm so grateful that you're here because like I said, you don't know, obviously this isn't a situation that any family plans for.
No. Totally.
Right. So just the opportunity to have this conversation with you and a little bit more understanding in like real life, what happens in an ICU and some of the hard conversations and considerations that are coming up. It's really, I think it's super, super helpful. Have you ever had to kind of navigate, you sort of referenced it a little bit. Do you need a minute? Are you good? Yeah. Okay. Yeah. Have you ever had to navigate a disagreement between family members about how to proceed?
Oh yeah, for sure.
Yeah.
Like I would say that's, disagreement, how we label it. Maybe, it might be labeled as, is there conflict? Is there, I sort of describe it as, are we all pushing in the same direction?
Yeah.
And you sort of, that gut check feeling before you go into a family meeting, you're like, there's something not right here. And I think it's because, and again, often the families themselves are having conflict, disagreement about what, what would mom want, that kind of stuff. Absolutely. But again, usually more time and just sort of, compassionate ear, empathizing that this is terrible. I'm not going to deny this is one of the worst things you're ever going to have to cross together, focusing back to the patient. But, I sort of, I was saying COVID derailed some of our sort of family plans, but, COVID as an example of like, when there's just straight up denial of information, that's really hard. That's really hard to navigate. Differences of opinion around prognosis and quality of life, happy to banter that. When someone says, I don't believe in COVID,
I don't think it's
this
a
is
thing.
the government doing, that kind of stuff. You're just like, it's tough. Like, where do you go with that? Like, I would say,
and like, it's not really the time to have a debate.
But when you just have said we can't agree on the facts coming to the table. Like, I've had family ask me not to put COVID on the death certificate, because they don't believe it. Like that, where you're just like, I don't know what to say to that. Like, other than I'm sorry, but like, this is the standard accepted medical opinion around what's going on. And like, I try not to get into a bun fight about it.
Yeah.
I would say most of the time, though, the conflict comes from, as we talked about, where it's so new, they need to feel that they've advocated for their loved one to the best of their ability. And it often just needs time to truly understand, like, so walk me through again, what does the MRI brain look like? And 4 different teams over the last 5 days have come by to say, and their best guess, this patient will never wake up to have a quality of life that I think they would want. That this is their best guess, and I think that doesn't fit. Like, I often find it needs time.
Yeah.
Let's say things like brain death, really hard to wrap people's heads around.
Yeah.
In the eyes of the law in Canada, North America, they're no longer alive. I'm not obligated to continue ventilating a patient, against, like, I'm not obligated to. Again, I try to, like, let's give time. Who else can come to help the family gather? Maybe, like, it's rare, but it does happen. And sometimes you're leaning hard on your colleagues, your ethical team, I've found it, just the cultural makeup in BC or in the interior, different than when I trained in Toronto, when there was a lot more nuance of cultural differences.
Yes.
It just hasn't been as much of an ongoing problem, but again, I find most of the time it needs time.
Yeah. I would be remiss, I think, if I didn't ask you about COVID.
Right.
And I'm not, not to sort of get into the discussion about is it a thing or not a thing. I think very clearly it was a thing for you and your teams in the ICU more than anybody. A lot of what I'm just going to, like, represent the common average Joanna, right? A lot of what we saw in the media, I think, was coming out of the US and the sort of overcrowding and the resource issues around COVID, in terms of, like, even just like beds and ventilators and all of that stuff. Was that as much of a, like, how was that for you?
It was tough.
Yeah.
I would say, like, we have a really strong provincial program in terms of support from ICUs in different places. So we have our regional sort of spoken of, but in the province. And I would say, like, my tagline is sort of reflecting back is, we had a couple of bad surges in Kelowna. The island had a couple of bad surges. We're up to, like, we run 24 beds. We're up to 40. We're running 40 patients. So it's absolutely decimating our numbers. You can't run any ORs. You can't run any clinics, like, because everything's pooling around. But the ebbs and flows never hit all of us at the same time. So we were able to shuffle to Vancouver. We would fly patients to Nanaimo, fly them to Victoria. Like, we're off cantering here. And then when they were surging in the north, we're bringing them down south. And, like, I went to work in Abbotsford for a week to help out because they're being crushed and we weren't. Like,
right.
So, like, we're shuffling people and resources all around. And, like, I don't know if it was planning or we got lucky or what happened, but we never had all 5 health authorities and PHSA massively under the gun at the same time. But we spent a lot, as the regional director, like, spent a lot of time planning for that. Like, we have 650 ventilators in the province at the time. And we're like, what are we going to do when we have 800 people that need them? How are we going to triage that?
So did you plan that in advance?
Oh yeah. Well, we had planned it back in 2012.
Yeah. Okay.
We had a document that we had worked on, but again, when really been under and SARS 1. I mean, I was there in 2002-3 in Toronto, and 400 patients, 40 deaths. Like, 10% mortality is high, but thankfully it wasn't very virulent. It's not like millions of people got it. But that got everyone's attention, saying like, "Oh, that like
we should have a backup
we should
plan.
be ready for
Yeah.
when this happens again." But hopefully, 1917 flu. Okay, it won't be for not my lifetime. And sure enough, here we are 20 years later. That in December 19 or 2019. So we had a document in 2012. We quickly revised it, but when you start looking at the numbers out of Italy and the States, we're like, okay, this is like we literally need. Like, so we were having these sort of, they called them, a 3-person sort of judiciary, like a 3-person adjudication committee that wasn't at the bedside, that would look at, I would submit, the idea was every morning I submit, here's all the people that I think need a ventilator, you guys write, here's all the bits and pieces around it. And again, like it was trying to be very much, the idea was to have transparency. But still, at the end of the day, you say, hey, there's 50 people that need the vent, and there's only 42 vents. These 8, I would have to go back to the families and say, I'm sorry, your loved one's not going to get one because of X, Y, Z.
Right. And
we never had to cross that. We practiced. We sort of had like almost, like tabletop exercises of how we're going to make this work. I mean, I lost so much sleep over that. Like when you're watching the numbers grow and grow, and you're like,
I can't even imagine.
Can't imagine us doing this for real.
Yeah. Yeah.
So, I mean, as I said, we kind of like Vancouver would be under the gun and Fraser was in trouble and we were hanging in okay. And so we moved patients up here and then we were going down there and we were flying. Like, I mean, it wasn't ideal, but we were able to make it work. And then when those floods happened and we got our ventilators cut off, so we realized like we need a cache of ventilators here that we don't have to rely on the highway to get them here. Like, honestly, we, through whatever mechanism, we were able to kind of.
So like, I don't think I'm speaking out of line here to say like that the health system in Canada is notorious, has a reputation for being a little slow.
Yeah.
You know what I mean? Like just generally, change is hard. Were you surprised at how nimble responsive the system actually became during COVID? I mean, I've heard that a few times.
Yeah, but I think like some of the, some people would argue like at the expense of a whole bunch of other resources. Like if you say like, yeah, we're going to prioritize COVID, let's get everybody thinking about it, working towards it, but we're not going to run any of our elective ORs. We're shutting down all cardiac surgery. Your cancer surgeries are being delayed. Like, there absolutely was this pendulum that for sure. And like, if you look at mid-March 2020, you walk through our ICU. A year, there's only 4 patients in the ICU because we cleared them all out waiting for this wave that didn't come as much as we thought it was going to just show up and start being miserable. So you've got a system that has some like tons of empty beds. And it's like, well, it's because we're getting ready for patients that they don't exist yet.
Right.
But you feel like, well, we can't be caught the other way, which is like our normal day. So today, 116% capacity, where you wouldn't be able to accommodate 3 COVID patients. So like somewhere there's a sweet spot. And I would say that some of the lessons that people are looking at is like, how do we be nimble, but not at the expense of months of wrecking look at the backlog we've still been working on trying to get through orthopedic, cancer surgeries. All those things are knock-on effects of. So I agree, the nimbleness to pivot and say like, okay, we're ready. We could have 800 ICU patients in the province. We're ready to go. But you have to. Those resources come from somewhere.
Yeah. Do you think we learned the lessons we needed to learn?
Yeah, I do. I think there's going to be ongoing research around, the way the system managed for years, as we start to see the tail of statistical impacts, and you say like, look at what we did here and the ongoing, like that stuff is all still coming out. Mm-hmm. Mm-hmm. I was really impressed with the nimbleness of the actual abilities of trials to sort out treatments. And like, you look very quickly. I mean, I was on the provincial, therapeutics committee, and we met, twice a week for the first 6 months and then once a week. And the ability to say, here's the standard of care, dexamethasone, tocilizumab, baricitinib, like boom, 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 boom. You hear the new trial came out. It's like, these are platform trials and multi-center, multi-country. Like, it was amazing. Some of the collaboration globally to try to sort out how we're going to help these patients.
Was survive.
It's unbelievable.
Yeah. Amazing.
I can't go past, because my mom's public health, right? A plug for vaccination.
Right.
You couldn't have told me at time zero, like within a year we'll have a vaccine that's more than 70% effective. You would have said there's no way. Like, you look at how crappy the flu vaccines work, but they're around 50%. Like, they're
Right. Mm-hmm.
So yeah, absolutely. I'm not debunking them, but if you had said we're going to be able to have it rolled out, like, you would have said there's no way. There's no way.
Yeah. Yeah.
And it literally over a year from, like, all those inpatients in Kelowna General were all unvaccinated because no one had a vaccine. It converted it to an outpatient disease. If you get a vaccination now, and again, through herd immunity, and, you need, like, I forget what Edith Blondell has a number that she's always, I can't remember if it's 75 or 80%.
I thought it was like around 70%. Yeah.
If you can get 80% of your population, the other 20 are going to get to kind of live under the healthiness of everyone else.
Mm-hmm.
But we hardly ever have inpatient COVID in the ICU that are vaccinated. It's converted it to an outpatient problem. I'm not saying people don't get COVID. It happens all the time.
Right.
But the ones who get really sick and die from it are badly immune suppressed, chronic comorbidity, cancer, lymphoma,
Right.
Like, it isn't a young person. Like, the number of 30s and 40s and 50 people dying from it in that first wave was terrible.
Mm-hmm. Mm-hmm. Totally.
So, I mean, it was a really, that scientific ability was really unbelievable.
Well, and just the swiftness of the rollout, like you said, it was.
I mean, they knew, like, anyway, it's a whole side story.
And yeah, you can, hindsight, right? Like,
Yeah.
And that's the thing. I think a lot of the times these conversations around the COVID response and pandemic response now, there's a lot of other narratives coming to light.
Yeah.
That's a whole other topic. But at the same time, hindsight is 2020. But when you're in it, when you're in the ICU, it's like, we need to help these patients now.
Mm-hmm. The ones in front of us.
Yeah. And the some may question the decisions and the rollout and the swiftness, but you don't know what would have happened otherwise.
Yeah.
Right.
Yeah.
So it's very interesting to hear it from the perspective of somebody who was actually working on the inside of healthcare on the front line, which we didn't really get a lot of that opportunity while it was happening for many reasons.
Yeah. I mean, I always, my kids and their mom, I always say the easiest thing I ever did during COVID was go to work.
Right.
So I didn't have to do all the
Totally.
all the society stuff. But I would say our team, the frontline nursing and, like, physician, I mean, people were pretty scared. You weren't sure, are you literally going to end up getting sick, and so most of us were, like, living in the basement, not near the family, trying not to eat with them. You come in, you change your clothes, you have a shower, you don't see anybody. That was 3 months, like, before we started to feel like, so yeah, I mean, like you said, it's a whole other show, the impact, but it was pretty impressive, like, and a very bonding.
Right.
It's like forged under fire, right? The people will always remember some of those.
Yeah.
But, like, I mean, the impact on society and the kids at home, and oh my God, like,
exactly.
I was like, oh, good, I get to go to work. Like,
yeah, totally. I mean, it was a lot.
Yeah.
I'm gonna say, like, you've spoken a lot about the most difficult aspects of your work. I want to know what brings you joy. Like, where's the light? Because you wouldn't keep doing it if you didn't like it.
It's really satisfying.
Yeah.
Like I said, you get to be in a front row seat and an active participant in trying to help. And we didn't get into the numbers, but, maybe I've painted too grim of a picture, but,
No. I don't
our
think
ICU, we run a mortality of the ICU beds around 20%. The regional centers would run mortalities around 8 to 12%. Like, they're a healthier population. We purposely bring in, remember, it's like the size of France, right? Like, we bring in the sickest of the sick and we do the best we can. And, like, 80% of the time it goes well or well-ish. I mean, some of that can be really satisfying. The team is really fun. I mean, we struggle always with saying, like, well, how do you not go home and cry yourself to sleep every night? It's like, well, you need to have some parts that are enjoyable. And we joke and we laugh. And
I think too, like, you kind of touched on it there, just when you're in the trenches with a team, right? And you go through these really dramatic events, there is that bond that you create, right? And there's that in and of itself is pretty special. We hear that
Totally.
time and again from our healthcare teams, is that one of the best parts of being in healthcare is being in
people you get to work
healthcare
with.
the people that you're working with.
And the families you connect with, there's some I keep in touch with. You know, you get a really interesting, as I said, a free pass to be right in the middle of some really amazing, beautiful things. And sometimes it's death, and sometimes it's survival. And they do amazing. They'll come back. One of our guys recently, it was a bad trauma, came back, walked through the unit. Like, it's so nice to see, and you sort of hug the guy, and it's neat. When I'm like in the grief world, one of the quotes I always tell the residents is that, like, to feel too much can be dangerous. Like, if you can't crawl into bed and take someone's illness over from them, but to feel nothing is tragic. So you got to engage a bit. Like, this is like human condition. You're trying to, you're along the journey, and you get this unique opportunity to be part of it, and to ignore that and just be like, here's a CT, your mom's not going to survive that. Like, is not. You're missing the whole point of this. Is about the shared human experience.
Yeah, the sweetness of life.
Yeah. Fragility, the beauty, and so, yeah, like you said, I mean, our team is amazing. We, if I was in the thick of a battle of like bleeding or cardiac arrest, like, there's no group that I would want more busting my ass with them together in the room. But when you have a successful outcome, yeah, it's a great group to celebrate the high highs and then more in the low lows.
And support each other through the low lows.
100%.
Yeah. I love that. And so what advice or insight or words of wisdom would you give, the young medical resident that's considering choosing a path in critical care?
I mean, I think it's a great subspecialty, and I think we didn't talk about what brings me, joy not at work, but we
didn't even get into that.
Yeah, but ICU allows, we talked at the beginning, the intensity, but there's lots of periods to take care of yourself, your family, outside of all that. So that balance, sometimes the work-life balance thing is really tough, and I think ICU can allow at least some of that, at least the opportunity. I would say, at the end of the day, like, you really need to be able to feel like it feels like a passion. That's probably, that it speaks to you and that you like it, because there's nothing harder than trying to get yourself to a job where you don't want to be there.
Yeah. And it's like, do you like people?
Yeah.
It
is. It's all about families and patients and their families.
Yeah. And I think it's funny because, we've spoken to numerous colleagues of yours, and I think there's a common thread that runs through even the surgeons. I'm surprised that, like, part of what gives them joy about their job is being with patients and families, right? And I think sometimes doctors get a little bit of a bad rap about bedside manner and this and that, and I understand that, because I do feel like your training historically hasn't promoted the relational aspects or the soft skills around doctoring. But from every single physician that sat in that chair, it's a common thread. It's like, I like people. Right? I care about the human condition, not just how to fix what's broken and cure what's sick, but be a part of that.
Yeah, 100%.
Yeah. I'm going to just kind of switch gears.
Okay.
How has your definition of health and what constitutes health changed over the years?
Well, I mean, I would say, and ICU unfortunately is very reactive, right? ICU is like, something's bad's going on and ICU is going to intervene. That's very much not that it ignores the social context and emotional well-being, and all that's super important. And I would say as the years go by, I feel more drawn to health being, the sort of that it's a multi-pronged approach to wellness. It's not just about stable heart rate, blood pressure, and level of consciousness. That being said, what's interesting to me is we used to very much just kind of measure mortality. How many people are alive at 30 days that came into your unit? The research now is way more interested in, like, at 1 year, who's back at work, who's got PTSD, who's got depression, how far can they walk in 6 minutes? So what are the physical things, emotional, psychiatric, anxiety, social ability to re-engage, and those are the outcomes that, like, families are way more interested in. If you say he's alive, but at home, no cognitive thought, can't work, can't take care of, I don't like having quality of life outcomes.
Is that health?
Yeah, it's way more. It's really interesting watching the ICU literature evolve over the 20 years. So I appreciate that personally and professionally, that healthcare really, or being healthy is way more than just the physical body's vital signs and like you said, emotional stability or emotional health, and thinking about it, and how do you take care of yourself before and after an ICU week, and that kind of stuff. So it's definitely evolved. I mean, I mentioned to you by email, my older brother passed away last year of a GBM. He was 51, and a close friend passed of ALS this past February. Like, I'm about to turn 50. You start to suddenly feel like a little more immortal and a little more like, what are the important things here? It's less about the material things I can accumulate, and more about the impact on your kids and your life. And so whether that's kind of folded into health, that's probably a little bit bigger than that. But anyway, that's certainly very relevant. That's evolved for me personally, and it speaks to a little bit, like, as I said, having watched my own family members sort of say, well, they never told us that about my brother. And I'll say, oh, they totally did. We didn't hear it.
Mm-hmm.
When you go through it personally on the other side of the gurney, I'm way more, I'm more, and whether it wears off, I don't know, but I find like I'm much more in tune with the idea, like, I'm not sure they're hearing this. I've said it, but I'm going to try to think of other ways to say it. I'm going to come back and do it again in 6 hours and again tomorrow morning.
Yeah. I really appreciate what you said about, the perspective that you get as you age.
It's your birthday.
It's my 50th birthday today.
What? Oh,
I know, right? Like, how crazy is that?
So you totally know ER and Grays.
I do. Yeah. And this morning I got a message from one of my friends that said, happy birthday. What is your biggest takeaway from your 40s, from your 40th decade?
Wow.
And I thought about it, and it didn't take me long to figure it out. I was diagnosed with breast cancer at 44. And so what happened, what I learned in my 40s is that I'm not going to live forever. Mm-hmm. And I also learned that I might not even live long. But what it taught me was that, and just lining that up with a lot of what you were saying about, the experience about being in critical care and ICU, mm-hmm. is like, those things, nobody plans for those things mm-hmm. to happen. Mm-hmm. And so here's me in my Yoda moment for my 50th birthday, if you'll permit me.
Yeah.
It's like, don't take for granted the day you have in front of you, right? And the people in your life, because you're not guaranteed any of it. Mm-hmm. And I think that for me, health has really taken on, of course, I'm so grateful for the system that is in place that allowed me to be able to sit here today, 5.5 years later, and say I'm cancer free. But I also recognize that I have agency in my own mm-hmm. health, mm-hmm. and that a lot of that has to do with the decisions that I make every single day.
Yeah, it shifts who you are.
Yeah. Yeah. And we all have that.
Yeah.
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 I love that.
Yeah.
What areas of so recognizing now that we're redefining health to be beyond just like, I can still ride my bike and, you know, like I'm not, you know, sick in bed. What areas of your life do you feel that you are wealthy or abundant?
Oh gosh, I'm super lucky. I have a lot of a lot of abundance. I mean, I have an amazing family. My kids, their mom Miriam, like my kids Ava and Judith. Like,
yeah, let's give some love for Miriam.
Absolutely,
your wife is just stellar.
Yeah. Judah's 15, Ava's 18. Like they're like young people. They're like doing their own thing, right? It's like, it's amazing. I find it inspiring, and we spent a lot of time together. I went to Tay with Ava in Seattle. That's Taylor Swift for non-Swifties.
I'm like, Tay-Tay.
What? You don't know Tay-Tay?
Oh my gosh, you're so cool, Ryan. What?
Me and Judah, you know, biking together. You know, so like we share time, we share joy, we share time away from the hospital. Like all that I love, and so I have so much abundance. My family, although my folks are back in Ontario, they spend some time out in the Okanagan. So my younger brother, the circle of friends I've had over the years locally, but also, you know, having been back east last weekend for a Memorial weekend for some of these events, like, yeah, it's been amazing. Amazing. I have my health. One of my mentors here, Cheryl Holmes, who hired me in 2009.
Oh, yes.
Her tagline at the end of her email forever was "Health is the new wealth," and I was like, I like that.
Oh,
yeah.
Well, Cheryl,
that's a good one, right?
I'm gonna have to call her, get her come do a episode. Yeah.
So, Anyway, I really have a lot that I'm super grateful for.
That's awesome. What areas of your life are you curious about or working on? I know you contemplate these things because I know Miriam, and she contemplates these things. So I'm sure it comes up at the dinner table. Yeah.
Obviously professionally and personally they're different, but the idea of like medicine never stops evolving, and the constant learning piece is always a battle, right? You feel like you could always do more. You could always take another course. I should hone my transcranial Doppler ultrasound skills. Like there's just things that are always on my to-do bucket list.
That one's not on my list.
It's not on yours, but where you feel like, and if you say to like anybody who works, you say like, what are you doing now that you weren't doing 10 years ago, that even 10 years ago, you're like, am I expecting to be doing that? Like, and so that's always a back, in the back of your mind. Personally or like I obviously like have, as I talked about, when you sort of confront, death and go through some sort of tough grief over the years, like recently, I'm much more interested in being more vulnerable. I've got a therapist I love, that's really been amazing. And, I'm happy to acknowledge that I don't have all the answers and I need help in certain times. And that's what I'm exploring. That's new for me. And to say no, because I've always been very much like, yeah, sign me up. And then you feel bad when you don't deliver and do a bad job. So
you're one of the things that I'm very grateful that you haven't said no to is being on our board of directors. Right. And so I'm gonna give you, because it is a volunteer role and you're on our strategic development committee, and I praise you for setting a boundary around the saying no, but I also just want to acknowledge that you give back in so many ways beyond just but beyond your career. You really help advance healthcare in our communities, and I think it's really brave to also talk about vulnerability. There's like so many things that I didn't even get to in this conversation that I would love to talk to you more about. But I think that's what we're all seeking, is just a little bit more opening between each other. It's part of why I wanted to do this podcast, is like to bring physicians into a conversation where you can talk about your humanness and be in a place where it's relatable and not just this ivory tower medical stuff. You know, you've lost someone in your life, 2 people, it sounds like, that are very close. And that's hard. And even though you work in an environment that asks you to be a part of questions of life and death every single day, you're still a person that goes through that.
Yeah.
And life is beautiful. And you know, one of the most beautiful things is that I've ever heard was in a poem by Shane Koizen, a spoken word poem that he wrote for one of our case videos, which was like a real coup because like he's a big deal. But what he said is, life isn't beautiful because it lasts forever.
Right.
So time is where the miracles live. And so that is, I think, a great place for us to wrap the conversation. Yeah. Is there anything that we didn't get to that you want to share?
No, I appreciate the time. I feel like an hour whipped by. That was
I know, right? I know. I'm like mad at Jason. He keeps telling me like what the time is. I'm like, no.
It's his fault, yeah.
It totally is, yeah. Oh. Well, appreciate you and appreciate all that you do up in the ICU here at KGH. We didn't even touch on some of your leadership roles, but you do a lot for healthcare in our region, particularly trauma care and coordinated critical care. You're invaluable on our board of directors, and you're also just a great person. So thank you for coming,
Thanks
Ryan.
For having me. Appreciate it.